There we go. We're down to our last proper day of lecturing, and then you guys have your final on Wednesday, huh? Just remember, you've got a final. Your exam will be on Canvas, so I'm going to try to reserve a computer lab for you guys on Wednesday. We'll meet here in this classroom, and then I'll take you to the computer lab. You'll go in, you'll do the exam on Canvas, and then we'll come back down and we will work on skills. So you guys are going to show me how to defibrillate, how to cardiovert, how to pace. Okay, should be simple stuff, right? Really simple stuff.
No more scenario?
What's that? Yeah, I talked about that. Maybe it was before you got here, and I think that the focus. I want to focus more on just the toolbox.
Oh, okay. Right.
Yeah, and then once we hit cardiology in August, you have the toolbox, then we can focus more on scenarios then, because at that point there isn't going to be much lecture for the most part with cardiology, because the conditions are the same, right? Cardiomyopathy is cardiomyopathy. Congestive heart failure is congestive heart failure. It's the same condition that you guys have already learned about. It's just that you have some expanded capabilities in some cases, but your bread and butter cardiology therapies are going to be what? Primarily basic and intermediate stuff, right? With the exception of rhythm disturbances, which we've talked about in this class. So you guys, at that point, you should know how to defibrillate, how to cardiovert, how to pace. You should know what medications need to be given. I don't need to go over that stuff again in cardiology. I don't need to re-lecture that. We've already had it here. We can just roll right in and actually start using it. So that's the plan. In fact, toward the beginning of next semester, we'll be doing ACLS pretty close to the beginning of the class. So you guys will be working scenarios right away, group scenarios. So, sound like a plan? All right, but I want to focus more on the toolbox, getting the toolbox ready to go here. Okay, so moving right along, we're going to talk about the QT interval, the last major thing that we need to discuss in class. All right, let's zoom in here. All right, so what is the QT interval? Let me change the color here. All right. So the QT interval begins on the Q wave, and where do you suppose it ends? Beginning or end of the T wave? End of the T wave, right? So the beginning of the Q wave to the end of the T wave. So if you see here, I have the QRS complex and the entire T wave, okay? So what does that represent? Well, it represents the total time for both repolarization and depolarization. And where does repolarization occur? Right, T wave. So you have repolarization occurring T wave and then depolarization occurring in the QRS. And we're primarily talking about the ventricles here. The atria depolarize during the P wave and repolarize in the QRS, right? It's the repolarization's buried within the QRS, so we don't actually see that manifest on your ECG. Okay, so let's just talk about some of the finer points of the QT interval before we go into what it is and what we use it for. And I think you guys already have an idea of what we use it for, because we've talked about some life-threatening dysrhythmias that result from prolonged QT interval specifically. But the QT interval is proportional to the heart rate, okay? That is to say, the QT interval will, does that say increase?
Okay.
No, negatory. The QT interval will decrease as the heart rate increases, okay? So my heart rate increases, and that will kind of squeeze the QT interval, decrease it. The QT interval will increase as the heart rate decreases. So as I become more bradycardic, I will expect my QT interval to become a little longer. Okay, I have more time if you want to look at it that way. All right. We know already that a prolonged QT interval is associated with life-threatening dysrhythmias, ventricular dysrhythmias, and what is the big baddie that we're all concerned about? torsade de pointe, right? TDP, that is the one that we're most concerned about, that potentially life-threatening polymorphic ventricular tachycardia, all right? There are some issues with a short QT interval, a QT interval that is too short versus too long. So I just want to make a note about that. Specifically, something called congenital short QT syndrome. Okay, this is where your QT interval is very, very short. Okay, this is a congenital problem. Okay, and this is associated with SVT, PSVT, AFib, and potentially life-threatening ventricular dysrhythmias. But we see a lot of tachydysrhythmias that may result from congenital short QT syndrome. Okay, so we know a little bit about what can affect the QT interval, okay, what physiologically can affect it, primarily heart rate. We know what life-threatening problems are associated with prolonged and too shortened QT interval, but what is a normal QT interval? That's probably a good question to ask, right? What's normal? It varies slightly between men and women. So a female and a woman, your normal QT interval is 350 to 460 milliseconds. And what does milli mean? 1,000ths, right? So milli doesn't mean a million, but it means 1,000th. So 350 milliseconds would be 0.35 seconds, right? Does that make sense? Because 1,000 milliseconds would be 1 second, right? So 350 to 460 milliseconds translates to 0.35 to 0.46 seconds. How many boxes is that?
Two big boxes.
Okay, so 2 big boxes would be about 400, right? Right, so average 2 big boxes, right? Or 10 little boxes. You guys okay with that? All right, good. Now, the male is 350 to 440 milliseconds, or 0.35 to 0.44. So just a little bit different than the female. It's a little tighter tolerance, if you will. However, at the end of the day, the number that you want to throw in the back of your mind is greater than 500 milliseconds, or half a second, 0.5 seconds. Okay, in both men and women, should be a significant finding for you guys. Should be considered high risk for torsade de pointe. Okay, so if you see that, okay, you should be concerned about torsade de pointe, and you should be concerned particularly about administering medications that could further increase the QT interval. You guys okay with that? Cool. So now we know some of the problems associated with it, what can affect it a little bit, and what a normal interval is. How do we measure it? Seems like a good question, right? Yeah. So we often will use lead 2. Okay, we'll look at lead 2. Lead 2 is really good at identifying the classic components of the PQRST complex, because typically what direction is the signal moving? It's moving directly in line with lead 2, right? Directly in line with it, so you get a good that's why it tends to be a good rhythm strip to use. So lead 2 is used. Okay, so as stated above, though, you'd think it would be just as simple as going to lead 2, finding the QT interval, and documenting it, right? You'd think that would be the easy thing to do. But what is it proportional to? Heart rate. So the heart rate changes it. So a slow heart rate makes it longer, a fast heart rate makes it shorter, which means that you need to compensate somehow for the heart rate. Or you need to, what we say, correct for the heart rate. What is the actual QT interval when we correct for the heart rate? That is the most important concept when it comes to QT interval. Not the actual, not what you find with boxes, but what the corrected QT interval is. So as we said, okay, it is rate dependent, and the heart rate must be accounted for. And this correction results in something called the corrected QT interval, or the QTC is the standard abbreviation for the corrected QT interval, the QTC. Does that make sense? That's the one. It is the most important for clinical practice, okay, for making decisions on what to treat somebody, how to treat them, what medications are you going to use. Are you going to use medications? Okay. There are about half a dozen different formulas out there that can be used. I don't know that there's any evidence to suggest one is superior to another. They all work in some situations and don't work as well in other situations. The common formula, or a common formula, that we use is something known as Bizet's formula or Bizet's method. Okay? And what this is it is a formula that we need to calculate, obviously, and it says that the corrected QT interval equals the QT interval that you calculate, that you find with the boxes, divided by the square root of the R to R.
That's not respiratory rate?
No, not the respiratory rate. The R to R. And I'll talk about what that means, because it's not the R to R that you are necessarily familiar with. But let's make sure everybody's on the same page. The formula starts out as the corrected QT interval equals the QT interval that you find when you look at the ECG divided by the square root of the R to R, whatever that is. You guys okay with that? Okay. Unfortunately, Bizet's formula may not be accurate for heart rates above 100 or less than 60. So if I have a normal heart rate, Bizet's formula is pretty good. But it can over or underestimate it if your heart rate is very fast or very slow. So we got to keep that in mind. Okay? So with that in mind, there are many other formulae, and like I said, there are probably about half a dozen that I know of. And there are many different phone and computer applications that can be used as well. Okay? I'm not necessarily going to say which ones, they're out there. You can find them. They, for the most part, generally work pretty well. Okay? But let's figure this whole Bizet's method out. How does that sound? Okay. So, let's try an example. So here I have 12-lead ECG. All right, so I've gone to lead 2. Let me zoom in here. You guys see that okay? So I've gone to lead 2 here. Okay. There's my Q. And then there's the end of the T. And what I found is that that's 10 boxes, right? You guys okay with that? Each box is 0.04 seconds, right? You guys okay with that? Or 0.4 seconds is also 40 milliseconds, right? So 40 times 10 equals 400. So the QT interval that I calculated, quote unquote, that I identified is 400 milliseconds, right? Or 0.4 seconds. Now that I have that, I have one piece of information that I can plug into my formula here, right? You guys cool with that? So the QT equals 400 milliseconds. Now let's find out the R to R. The easiest way to find the R to R, okay, is to divide 60 by the heart rate. Okay, so if I go up here, 60 divided by the heart rate equals the R to R. You guys okay with that? Okay. And again, this may not work as well if you have a very irregular rhythm like AFib. Okay, something going on there. That R to R obviously is going to vary quite a bit. But if you have a fairly regular rhythm, this is a good way of finding that. 60 divided by the heart rate. So let's go here. So in this particular case, the heart rate is 60. Okay, so what would be the R to R here? 60 divided by 60 equals 1, right? So if I rewrite the formula now with all the information, the corrected QT interval in this patient would be 400 divided by the square root of 1. Okay. Now, you guys all have calculators on your phones, right? How many of you guys have iPhones? Raise your hand if you have an iPhone. No? Okay, a couple of you.
Sideways.
Okay. Turn it sideways and tell me where the square root button is, or the square root option is on your standard iPhone calculator. I can't speak about Androids, but do you see it anywhere there? Oh, no. Oh, no. So now we have to use a little math. Okay. Mind blown, right? On your standard iPhone, I mean, you may have another app, but just a standard calculator may not have it. So, let me ask you a question.
Yeah, those three are different.
Right, yeah, you won't have a standard square root option. So let me ask you guys a question. Let me ask you a question. Mathematically, when I take the square root of something, what is an equivalent way of stating taking the square root?
Two equal numbers that equal.
Right, so something multiplied by itself equals the number, right? So let's say 10. Let's just say 10. So the square root of 10. So what that's telling me is something times itself, right? Something squared equals 10, right? Would you guys agree? Okay. So what would be another way, an equivalent way of describing that relationship mathematically?
Here's something to the half.
There you go. So something raised to the half power, right? Not squared, but to the half, is equivalent to square root. Are you guys okay with that? Right, this is just kind of, high school algebra. So x is the number that we're dealing with, right? Whatever number, it could be 10, right? Whatever. X to the 1/2, raising something to the power 1/2 is equivalent to taking the square root of it, right? So if you go to, and again, I'm focusing on iPhone users because I know this is an issue with iPhone. Okay, so remember, square root is taking some number to the power half. The square root is also known as x to the half. Okay, so this is what you want to do. Go to your calculator, type in whatever you get for the R to R. Let's use 10, okay? So go to your calculator, put 10 in if you're using an iPhone. If not, then you may just have a square root and you won't have to worry about this, okay? All right. Put your phone into its landscape mode. When you turn it into landscape and you have unlock off, it'll give you a whole another bunch of options, right? You guys see that? All right. Find x to the y, okay? X raised to the y. Do you see that icon on your options there on your iPhone? X to the y. You guys see that there? Select x to the y. Type in 0.5. Okay, so what you're basically telling the calculator to do is to raise 10, the R to R that you put in, to the half, or the 0.5. Then hit equals, and what number do you get? Say it again? 3.16 dot, 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 whatever. That is the square root of 10, okay? Sorry, you iPhone users are special. I had to go through that. But,
Little bus special?
huh?
Little bus special?
But, yeah. Now, if you just have a plain old square root button, okay, fine, that works as well. But if you don't, that's how you do it. You guys okay with that? Okay, so let's now move on to our example here. What is the square root of 1, though? 1, right? So that's easy. So 400 divided by the square root of 1 is just 400, okay? So that's a basic, simple, easy math example of how we can use Bayes' formula to find the corrected QT interval. Okay? You guys okay with that? Now, obviously, at a heart rate of 60, not a whole lot of corrections needed, right? But once you get slower or faster than that, then that's where that correction factor becomes more relevant. Okay? You guys okay with that? Well, that seems kind of common. So, is there another way to find the QT interval? Yes. And this is what you should do. Okay? This is what you should do. You go to your 12 lead, you print your 12 lead off. All right? And you go to the information area on that 12 lead. Okay? And remember, we already talked about finding your axis, right? Specifically, your mean axis there, looking at the R, right? It's 81 degrees. Well, just above that, on the ZOL, it may vary, the location may vary depending on the monitor you're using, but you're going to have a QT/QTC there. Do you guys see that there? What that is your actual QT interval and your corrected QT interval. The software in your 12 lead will calculate the corrected QT interval for you in most cases. You guys see that there? And what I did was I actually did my own calculation here. All right, so I went up here. Okay, I calculated about 440 milliseconds for the QT interval. All right. And then I went ahead and I did Bayes' formula. So I put 440 in. All right, the heart rate was 55. So if we go up here, heart rate of 55, you guys see that there? So 55 divided by, or 60 rather, divided by 55 gave me 1.09. I took the square root of that, 1.04, more or less. And then 440 divided by 1.04 gave me 423 for my corrected QT interval. And then I compared it to what we got here, and you can see there's a little difference, huh? Okay, they don't quite match up. All right. And again, this color here, this pink color is my actual, what the computer calculated is the actual versus the corrected here. There is a little difference. Okay, so in conclusion, it's going to be a lot easier to find the QT interval on your printout than having to do all this math, right? So it's actually not as hard as in practical sense, getting away from the classroom and working with the numbers. In a practical sense, when you print a 12 lead off on somebody, you can just go to the corrected QT, and then the big number that you want to put in the back of your mind is 500, right? Greater than 500 milliseconds, or 0.5 seconds is going to be significant. Corrected, right? You guys okay with that? Okay. So far, so good? All right, so now let's talk about the major causes for QT interval abnormalities or anomalies. All right, first of all, there are many medications. This is one of the most common side effects of medications that are on the market or being produced today. QT interval prolongation. Okay, it's like one of the top two. I believe the next one is enzyme interactions, CYP, cytochrome P450 enzyme interactions is the second. All right. I want to include a few examples, but this is by no means an exhaustive list. Antipsychotics are really good, a prolonged QT interval. So things like haloperidol, okay, Thorazine, okay, or Haldol. And antiemetics. specifically antiemetics that are structurally similar to antipsychotics, the phenothiazines, of which there is one that is commonly used in the EMS environment. It's kind of being phased out a little bit, but it's Phenergan or promethazine. Promethazine is structurally, chemically, it's very similar to thorazine, believe it or not. Very similar. It's very similar properties as well. All right. Some antidepressants as well, right? Your tricyclics, your TCAs, right? They widen the QRS. That's going to widen the QT interval, right? Your MAOIs, some of the SSRIs may as well. Okay. Most of your sodium channel blockers, specifically your 1A and your 1Cs. Okay, so throw some examples of your fast and your slow channel sodium channel blockers. Throw some examples at me. What's one that is actually still in your AHA algorithms? It's the one that I want you to know. Huh? It's a sodium channel blocker, right? What are they used for?
That's a slower rate. What's that?
Lidocaine is the only sodium channel blocker that does not significantly impact the QT interval. And lidocaine is a class 1B, right? It is an intermediate channel. So it does not impact the QT interval very significantly. But there is one that does. Those of you guys in pharmacology right now, you better know this. Because there are endpoints to administering this medication even.
Oh, amiodarone.
Is amiodarone a sodium channel blocker? Sodium channel blockers. That's what I want. Sodium channel blockers. Does that ring any bells there? Procainamide? Is that on your algorithms? Do you have them there? Yeah, that is in the ACLS, right? They're on that side column there. Procainamide. What are the endpoints to administering procainamide, guys? There are two major endpoints. I believe it's like a 17 milligram per kilogram load.
Yeah.
And there are two major endpoints to procainamide. Come on, farm.
When you say endpoints, like contraindications or whatever?
No, endpoint is like, okay, I need to stop giving this now.
Oh, okay.
One would be prolongation.
Yes. If the QRS complex
Greater than 50%.
is greater than 50% of baseline,
Or maximum dose of 17.
or you've given your maximum dose, or the blood pressure takes a hit. Yeah. Right? Right? Does that make sense? So if your QRS complex is 0.08 seconds, what would the baseline be? What's half of 0.08?
0.04.
So your endpoint would be 0.10. Does that make sense? Right?
Yeah.
0.08, half of it is 0.04,
So wouldn't it be 0.12?
12, yes. There you go. Yeah, 0.12 seconds. Yeah, there you go. Does that make sense? All right, good. Yes, procainamide is a big one. Let's see here. Let's talk about antiemetics, promethazine. Do you think that ondansetron, what is ondansetron? Zofran.
I saw a study that they were seeing prolonged QTs with it,
Yes.
but it was showing, the way I understood it, was more of a heavier IV dose, and they were saying like
Yes.
32 milligrams.
For cancer. Right. When we talk about giving, that's actually, ondansetron was designed for chemotherapy. It was not designed for paramedics to throw at every patient that they run into, right? It was designed as a pre-medicating agent. And it still is used as a pre-medicating agent for chemotherapy. And you might give up to 32 or more milligrams, a massive dose of it prior to initiating the round of chemotherapy to attenuate the nausea and vomiting. And at those larger doses, it does become more of a problem. I am aware of this. It's pretty rare, okay? It's pretty rare. So why am I talking about something that's really rare? Well, because we give a lot of Zofran out, right? And even something rare is going to happen if you do it a lot, right? If you're giving a lot of Zofran, even if there's a rare problem, you're giving so much of it, you should be aware. I'm aware of it happening once. It was actually a friend of mine who was in the hospital with diverticulitis, and he ended up getting a 4 milligram dose of Zofran, pretty standard dose, and ended up getting really bradycardic, and his QT interval got prolonged. He didn't have torsades or anything, but yeah, it hit him a little bit. So keep that in the back of your mind. Other ones like anapsine or droperidol, not as commonly used in this area, but it can also prolong QT interval. All right. Potassium channel blockers. What is your classic potassium channel blocker? Amiodarone. Yes, amiodarone. And many antibiotics as well. Many antibiotics will prolong the QT interval. And are antibiotics part of our scope of practice? Yes. All right. Antimicrobial therapy is, right? So in pharmacology, hopefully you guys talked a little bit about antibiotics. Not in specific, but you should be aware of some of the classes, right? The macrolides, the tetracyclines, okay, et cetera, et cetera. All right. Other causes that you might run into: elevated intracranial pressure. People have head injuries, cerebral edema, or hydrocephalus. That can cause not only a bradycardia, but it can cause the QT interval to become prolonged. Getting really hypothermic can as well, right? Those Osborn waves develop those J waves, and that's going to prolong. Even severe myocardial ischemia, people that have been in cardiac arrest, and we get ROSC, okay? They're really, really ischemic. They may develop prolongation as well. Big one here is congenital long QT syndrome. And this has been known to actually cause sudden death in people who are otherwise healthy. An otherwise healthy person collapses dead. This is one of those things you want to think about. Do they have congenital long QT syndrome? Do they have old Parkinson's white? Do they have Long-Ganong-Levine, right? Do they have some sort of channelopathy? There are a whole list of things you want to be thinking about there. And electrolyte anomalies, specifically hypokalemia, hypomagnesemia, and hypocalcemia. What is hypokalemia? That is a low potassium. What is hypomagnesemia? A low magnesium. And what is hypocalcemia? A low calcium. Okay, you guys okay there? All right, cool. So let's look at an example here. So here I have an example of congenital long QT syndrome. And I shamelessly stole this from Life in the Fast Lane, but they have a Creative Commons license, so as long as I give them their due credit, right here's the link. You can find this picture. I've given them their credit. And so you can definitely see right here, and maybe I'll zoom this in a little bit here. It's still going to be a little hard to see here all the way out to here. How many boxes? 3, almost 4, not quite 4, but 3 3/3. So that's 0.2, 4, 6, 80.
Well, I thought you started on the Q, not the...
Oh, whoops, yes. Thank you. Nice catch.
So 0.6.
Yeah, so there we go. 2, 4, 6. So that is approximately 600 milliseconds or 0.6 seconds. Good catch there. So definitely prolonged. And would you assume that even if you did a corrected QT interval calculation, is that going to change it? No, in fact, because this rhythm looks, we don't have a rhythm strip, but it looks rather slow, it's the corrected QT interval very well maybe even a little longer. So clearly very long, so clearly this patient is going to be at risk for what? torsades, which can cause them to go into rest, which can cause somebody to collapse suddenly and die, sudden cardiac death. You guys good with that? All right. Right along here. Okay. So let's not neglect the QT interval. There are fewer things that can shorten the QT interval, and it's not something that we spend as much time talking about. But the big one is congenital short QT syndrome. Okay? And this is one of the things, along with long QT syndrome, Wolff-Parkinson's-White, Long-Ganong-Levine, channelopathies, and a whole variety of single nucleotide polymorphisms that can cause channel defects. If you have a young person who's healthy that suddenly dies, okay, these are things that need to be considered. All right? Even though you may not be able to help that patient, you may be able to help their family, because these are things that can run through family germ lines. Okay? And so when somebody dies suddenly, okay, and the investigation starts, that's something, if you're in the vicinity they're talking about, that's something that you probably want to mention. Hey, we should rule out things like short and long QT syndrome, channelopathies, SNPs, SNPs, those kinds of things. Does that make sense? Right? We might be able to save somebody else in the family. Okay? So yeah, short QT syndrome, channelopathies, other genetic cardiac defects. So here is an example, shamelessly taken from Life in the Fast Lane again, of a congenital short QT syndrome. And one of the things that you get with short QT syndrome is you can actually get these peaked T waves. And so this may actually push you to initially assume what? You may initially look at this and go, oh no, this is hyperkalemia. Okay, again, that's why it counts to, let's look at the QT interval. All right, so Q wave here, T wave here. All right, we'll go down. Let's see if we can find one that's, maybe on a box. And we can, it's going to be hard because it kind of gets obscured a little bit, but... Yeah, 5, 7, approximately 7 boxes. So what's that? What does that equal? Or 40 times 7. What's 4 times 7?
280 milliseconds.
There we go, 280 milliseconds approximately. Is that short?
Yeah.
That's less than, what, 350, right? We said about 350 is our cutoff, so this is shorter than that. So these patients are going to be higher risk for things like SVTs and possibly ventricular problems. Okay, you good with that? So not all peak T waves are hyperkalemia. Okay, other things can cause peak T waves, right? Hyperacute ischemic changes, short QT syndrome, among some other things. You guys okay with that? Cool. All right, moving right along. What I want to do now is I just want to give you a little case study. And I've shamelessly stolen this from another paper. It's a really nice, well-written case study, and I'll give you a link to that if you want to read the whole thing. Yeah.
And there's no reason to treat that, though, right?
No, there's no reason to treat this. Yeah.
Note it when you...
Yeah, so if you... Yeah. Or let's say you have somebody who you found down, at the grocery store. They're lethargic, they're diaphoretic, they're an SVT. What do? You cardiovert them, and they go into a sinus rhythm, and then you're done, right? All right, hooray, I did my job, let's transport, right? No, you should do what? You should run a 12 lead on them, and you're looking at the 12 lead, and you go, ooh, get that QT interval. And you start talking to your patient, hey, has anyone else in your family ever had a problem like this? Oh, yeah, my little brother died when he was really young, I don't remember. And then all of a sudden, that opens up this whole spectrum of stuff that you can then dump on the receiving facility and go, hey, this is what happened to my patient, here's a QT interval, and it sounds like there may be some history in this guy's family. When the family gets here, maybe we should talk to them about some genetic counseling, right, to pick this up.
Is there a treatment?
There is.
Outside of us?
Yes, oftentimes these patients will have an implanted cardioverter defibrillator put an AICD in, it's also used for other things like Wolff Parkinson's white. Occasionally, people with Wolff Parkinson's white don't respond well to ablation therapy, so we'll put an AICD into them as well. Yeah. And long QT syndrome as well, an AICD may be what's treated, or what would be the definitive treatment for that patient. There's some really good videos on YouTube of soccer players. There's one really good one where he collapses, just dies right there out in the field, and then you actually see him twitch a little bit as he had an implanted cardioverter defibrillator. It defibrillated him, and then he went back into a sinus rhythm and kind of regained consciousness. Yeah, so yeah, they do work. But again, it may be up to us to make that call, to find that information and get the ball rolling, right? Even if you can't necessarily save your patient, you may be able to significantly impact the family. And I'll tell you, ERs are busy places, right? The nurses, and I know this because I worked for many years as an ER nurse, the nurses just don't care about the minutia in a lot of cases. Why? Because I've got 7 patients, I've got admits, I've got a lot of crap going on, and I may not be as focused in, whereas you guys typically going to have one patient. You're going to have that focus. If you can, try to get that information. Try to make these connections and make these calls, because believe it or not, you can really impact, right? You may not get the credit at the end of the day, right? The family may not say, oh, that paramedic saved all my brother's lives, right? They'll probably say, oh, the doctor found this out, right? It happens, it happens a lot, but at the end of the day, we're not in this to get accolades and pats on the back, right? This is the wrong field for that kind of stuff. But at the end of the day, you can make a very clear impact on people, and you're not necessarily even treating, right? You're just getting information and conveying it along. So just things to think about. All right, so let's do a case study here. So I believe this is in Europe, but I'll give you a link to the actual article because it's really good. It's really well written. It's not very long, and it's just a pretty easy read. It's a case study. So you have a patient that was admitted, was having PVCs here. Okay, so he's having PVCs. So here's the strip upon admit. Okay, it's kind of hard to see. I really had to enlarge it quite a bit. But basically, we're looking at a sinus rhythm with PVCs here. You guys good with that? All right, so I got a sinus rhythm PVCs. So apparently the PVCs were getting problematic. They were kind of worried about them, so what did they want to do? They wanted to treat the PVCs. What's a common medication we give to treat them with? Amiodarone. So they initiated an amiodarone infusion. Okay, and then the PVCs went away, but automatically we found that the QT interval kind of got prolonged there. You guys can see that there. Okay, so we got some QT interval prolongation. So what do you think may have occurred here?
The amiodarone caused it.
And what do you suppose might that have precipitated? Might have precipitated torsade de pointe, right? Maybe. Now, this is relatively rare. Let me be honest, this is a relatively rare. I think it's like 1% of patients that get amiodarone. But you guys have nice long careers ahead of you, right? And if you give amiodarone, 100 times in your career, you may have this happen 1 out of 100, right? This may be something that you'll see in your career or see with somebody else. Okay? So, yep, how about that? So the patient experienced torsade de pointe right there. So what do you think they did with the amiodarone? They discontinued it. How about that, huh? And this is kind of cool. And then that they did is they did serial 12 leads on the patient, and we had pictures of. So here's 4 days after the amiodarone. You can see the QT interval is pretty prolonged here, huh?
Yeah.
Look how prolonged that is. And then at day 5, it's still pretty prolonged. Day 9, what do we see? It's starting to shorten. And then they stopped at day 14, but you can see what, just eyeballing, it looks to be a reasonably normal QT interval, maybe a little long, but you can see that it has gotten shorter over, a course of about 2 weeks, all right, following some cessation of the amiodarone therapy. And so I was, again, just for copyright, all right, we use these for educational purposes only. I'm not getting paid when I put this video up. This is for you guys to use as a study. And they have a Creative Commons license as well. And I have the link to the original article right here on ResearchGate. It's kind of an open access journal. It's a really good article. It's only a few pages long. So if you want to reference that, the link is right here. And of course, these notes will be loaded into Canvas for you guys as well. So at the end of the day, QT interval. Too long and too short can make us develop high risk for ventricular dysrhythmias, specifically torsades. When it's too long, what are our thresholds? Over 500 in both men and women, and under 350, right? You guys okay with that? Okay, the major causes of prolongation are going to be drugs, right? Drugs, you should be able to identify some of the major types of drugs that can do it. Antipsychotics, antiemetics, antibiotics, antidysrhythmics, specifically your potassium channel blockers and your sodium channel blockers. Okay, some other things that can cause it: ICP, elevated intracranial pressure, congenital QT interval prolongation or long QT syndrome can cause it as well. All right. Electrolyte imbalances, specifically which 3 electrolytes? Magnesium, calcium, and potassium. Hypomagnesemia, hypocalcemia, hypokalemia. Right? Yeah, it's all right. You guys got that there? Okay, good. So what should we do if we see torsades?
Right.
Okay, yeah. So torsade de pointe, stop if you've administered something, right? If you, let's say you initiated amiodarone, stop the amiodarone. How do we treat this?
Magnesium sulfate, 2 grams, and unsynchronized.
Right, so we go, are they unstable, right? Are they stable or unstable? Are they unstable? What do we do if they're unstable? Yes. How do we treat them? Right, defib, unsynchronized shock more than likely, and then mag sulfate. If they are not unstable, we mag. So either way, they're going to get magnesium. Okay, and then try to identify underlying problems that may cause it. Right? Is there calcium low? Do we need to give them some calcium? Is there potassium low? Can we give potassium as paramedics? Can we give potassium as intermediates?
We can monitor for transport potassium.
Right. What is your threshold as an intermediate for?
10 to 20 milliequivalents per hour.
No, as an intermediate.
Yeah, hey, we can monitor the rate of that.
What's your maximum rate though?
20.
Is it 20?
Yeah, 20 milliequivalents per hour.
Is there anything else associated with that? Like a concentration?
With cardiac monitoring.
You have to have a cardiac monitor, yes.
It's 10 to, for adults, it's 10 to 20 milliequivalents per hour IVIO.
Right, but as an intermediate, what is your scope of practice as an intermediate regarding potassium?
That's it,
Sure?
as far as I've ever known. That's,
These questions, you might say no.
that's what I'm thinking, that's why I said anybody else.
So
know
you
anything?
cannot give any more than 20 milliequivalents per hour, but there is another layer to that.
Something to do with your.
It has to do, well, first of all, your rights. What are your rights of medication administration? Throw them at me, guys. Right patient, time, what else? Route, right dose,
Concentration.
right concentration,
Right documentation.
right documentation,
Route.
got the route there.
That's
That's
it.
it.
Good. Okay, so we have the right patient, the right time, right route, right dose, right? No more than 20 per hour. We document it. What does that leave us with?
Concentration.
Oh, can we have different concentrations of potassium?
Yes.
Yes. Is there a concentration limit as an intermediate in the state of New Mexico?
Yes.
Yes. Right? I believe it is no more than 20 milliequivalents per liter. Right? You cannot have it any more concentrated than that. But as you guys know in pharmacology that are taking it, there are many forms of potassium that are more concentrated, right? And these are known as sometimes they're called K-riders or a K-run, where you give a highly concentrated dose of it, like 20, 30, 40 milliequivalents in 50 milliliters. All right? You're giving a relatively large dose, concentrated dose, in a small volume. All right? You guys talked about this, or no? Oh, good. Good, we're talking about it now. All right? You cannot, as an intermediate, give that concentrated a dose. Even if you're just monitoring it and your patient's on a cardiac monitor, you cannot. It's outside your scope of practice. Can we, however, as paramedics, give more concentrated doses of potassium?
Yes.
We can, right? If a K-run or a K-rider has been initiated, we can, right? But as is the case with intermediates, the patient needs to be on a monitor, and we should have that patient on a pump as well.
Says it has to be. I
Yeah,
can pull up the
has to be on a pump.
Yeah.
Right.
If it's under 20,
Yes.
does it have to be?
If it's under 20 per liter, right?
Right, per liter.
But if it is more concentrated than 20 per liter,
Then it has
you
to be on
need to have a pump. See, half of paramedic school isn't necessarily learning pathophysiology and stuff. It's actually learning about what our guidelines and protocols and scope of practice say. You guys see that okay there? Okay. So if you're giving a K run, you've got to have a pump. All right. You can't put a dial-a-flow on. Right. You've got to have a pump. So if you're pulling somebody out of hospital, that means that they better give you a pump. Or can you transport that patient? No, you cannot. It is outside of my scope of practice as a paramedic to do that. Does that make sense? Another thing to know about potassium, I know we're kind of going off the rails a little bit, but this sounds like this is something that needs to be covered anyway. Concentrated potassium tends to be exceptionally painful. Okay? Exceptionally painful. So if you're going to give it, what kind of IV should we have? Should have a large line. Ideally, your patient should actually have a central line in place. They're getting concentrated potassium. Ideally, they should have a central line placed. You guys know what a central line is? Okay, yeah. It's generally, they come in all different flavors, right? Broviacs, non-Broviacs. You've got your tunnel, non-tunnel, but it's a large, long catheter placed in a central vein, like the subclavian vein, occasionally the femoral vein, but subclavian tends to be the common one.
What causes it to be so?
Huh?
What causes it?
Well, it's a highly concentrated ion, right? But potassium is positively charged. It's a metal, right? So it has some chemical reactivity to it, and it's highly concentrated. Yeah. So it can cause. Have you ever been around somebody who's gotten it? It can cause excruciating pain shooting up the vein, really irritating to the vein.
It's like direct irritation to the venous wall.
Yeah,
and stuff.
it's very irritating. Yeah, so something you want to think about. Yeah, you guys okay with that? I know that's not directly ECG related, but still really good. I think a really good conversation to have, nonetheless. Okay, let's cut it off here.